Hello again.
Hello.
Sorry, the link now is working to Facebook as well as YouTube. If anybody is watching this on Facebook and wanted to watch it on YouTube, there's a new link. I just reshared the YouTube link again. Very sorry about that. I don't know why it didn't link automatically. So, starting 10 minutes late. Apologies. Welcome, Caro, again.
Me again.
So everybody, I just want to do a little introduction to professional ed and how it works for those of you who are watching for the first time. Because excitingly, we had a few new members sign up just for this one now. I just want to remind everybody that the audience that this is for, it's mainly physios in this group. There's about 85 of us in this professional ed group now. Mainly physios, but a mix of physios and some allied health and fitness professionals, Pilates instructors. So it's a group of people who are passionate, like Caro and I are, about women's health and exercise. So the topic tonight is on pelvic girdle pain and exercise. It's not the first time we've done this as a continuing ed, a professional ed session. But in the past, when we've done it, we did it face-to-face and got really, really good feedback. Everybody loved you, Caro. Everyone thought you were fabulous. And I got asked by quite a few people to have this again. And this time we'll be able to have a recording like this with the screen up and have it really good quality recording for everyone to watch again after. So could everybody comment either on their YouTube comment or on Facebook, your name, because if you're on Facebook, I actually can't see your name on here. It just says Facebook user. So your name, your profession, and where you're watching from, so that by the time Caro's done her intro, I can read them out to her and she can see who she's talking to. So can you all do your intros by typing in? And Caro, I'll hand over to you. Can you let us know what you do as work, what your training has been, and why you enjoy this area, pelvic girdle pain?
Yeah, cool. So I am a physio. I have been working with musculoskeletal patients and a mix of women's health and musculoskeletal, but mainly rehabilitation of musculoskeletal pain. I do work with women's health physios, crossover together. I have done Terran's FitRight training as well some time ago. So I use a lot of clinical Pilates, strength and conditioning training, and I'm also a yoga instructor. So I kind of mix a bit of everything. I have a clinic, Eric Street Physiotherapy and Movement Centre in Cottesloe, and with a large studio area. And I personally tend to see many outpatients, obviously, in clinic, but the more complex type of patients, the ones that didn't get better anywhere, that have a combination of presentation, not just musculoskeletal. Usually there's more chronic complex pain problems and other factors like lifestyle or general health issues.
Okay, great. Yeah. Do you see many of the pregnant population for pelvic girdle pain?
Yeah, it comes and goes because we've got a women's health physio in clinic, and she does pregnancy classes in this, semi-private kind of setting. They tend to do quite well. So by the time, if they come and see me, maybe later or either when they have a growth spur around the 24, 25 weeks or later. But if they're attending the classes, they usually see me for 1 or 2 sessions, a bit of education, activity modification. They do quite well. The other ones that get referred to see me, usually they've seen some other physios before, so had some sort of treatment, but they're not getting better. A lot of times the source of pain is not coming from the pelvis, so it's a hip or back, or they have sort of a long history of endometriosis, chronic back pain, and need a slightly different approach. And then postnatally as well, that anytime from fresh 6 weeks to a few years later when there's like 2 kids down or second pregnancy. A variety of clients. Yeah.
Great. So we'll bring up your slides in a sec. We will, I think they've been shared already. If these slides haven't been shared already, they will be shared afterwards for everybody to refer back to. So Kara's going to share her slides and we'll go through the talk. It'll be, we estimate maybe 45 minutes of talking, over which time Kara would really like you all to engage. I don't know if you're going to ask questions of the group throughout, Kara, but if anybody's got anything to add or comment, please do. Caro, that we've had, there's about 9 people watching, but 4 of them have commented. Bronwyn, who's a physio in Sydney. Jo is a physio in Perth. She's one of the FitRight instructors. Felicity Munro, pelvic health physio in Perth. And Kat Von Felton, she's a physio Pilates yoga instructor in Perth. So welcome to those guys and to everyone else who's watching. Okay, so let's get started. I'll share your stream, and if you can swap it to the slides.
Yeah. So when I put this together, I had in mind, I think the first time we did it, we had quite a mix of physios and health professional, fitness professionals. So some things will be a bit obvious for the physios, but for the health fitness professionals that are looking maybe on replay to know what we do, and people that work in group classes, what, I usually give individual advice because that's my clinical setting, but what you can sort of advice you can give in a group setting, and why you should see someone one-on-one as well. So it's all there. So just what
sorry, just before you start, on your screen it's got a thing that says like stop sharing and hide. Can you see that? You just press hide. Oh yeah, I'll put it down. Yeah,
they're good.
Thanks.
They're good.
Yeah, that's good. Thanks.
Yeah. So what pelvic girdle pain is, more in pregnancy. But that's for any presentation really. It's a collection of signs and symptoms and discomfort around the pelvis and around the lumbar pelvic area. Anything radiating from the pelvis to the upper thighs and perineum. And the symptoms occur due to, we use the term more sensitization of the pelvic ligaments and increased joint mobility in pregnancy. You've probably seen a little guy coming here. Symptoms may vary from mild discomfort to severe, but can vary because it's all subjective for each person. Other causes of pain in the pelvic area that are not musculoskeletal could be UTIs, preterm labor, and that this kind of thing should be excluded. And pelvic girdle pain usually resolves spontaneously, so that's an important thing to tell clients. Can be really severe, but tends to go away after birth. And
what are you doing?
Baby, mum is working, so go to the. And may symptoms may recur during other pregnancies, but doesn't mean that you had in one pregnancy that you have the next one. Pelvic girdle pain in pregnancy, the cause is unknown. There's some low-level evidence that they are contradictory, ranging from 4% to 84%. So that's a huge range, and the causes can be attributed to the absence of a precise definition, the diagnostic criteria. So that's why the range from 4 to 45. And pelvic girdle pain tends to be higher in late pregnancy. That's when people are like struggling a bit more with seeing in clinical practice. So some factors that can influence pelvic girdle pain. So low level evidence, previous history of low back pain, increase of number of previous pregnancies, physically demanding work, emotional stress, and the evidence on age as a risk factor for pelvic pain in pregnancy is inconsistent. I had someone recently coming with a long history of endometriosis, back pain, disc problems. She was works in, I think, at Fiona Hospital as a radiologist, so lots of bending, quite a heavy work. And she struggled a lot with her, like early on, like first weeks of her pregnancy, and she was set that her pregnancy was going to be terrible. But in fact, we did work with her throughout the whole pregnancy, and towards the end, like third trimester, she was doing really great. I'll talk more about her case as we go. But it was like the heavy work. We had to do some modifications and some specific retraining so she could work and do the bending and the twisting and lifting with pelvic girdle pain in different stages of pregnancy. So intervention in pelvic girdle pain, systematic reviews into interventions for women with pelvic girdle pain have found low level evidence. So I put a few different things, but it all comes back to a multimodal approach with manual therapies, some exercise, and patient education. So we say advise women in experienced pelvic girdle pain that pregnancy-specific exercises, physiotherapy, acupuncture, or using more support garment may provide some pain relief. I would say that more towards the end of pregnancy. So management, when we're giving the general advice, just explaining the bones of the pelvis, where and showing maybe on the model where the source of the pain is coming from, could be at the front, at the pubic symphysis, or the sacroiliac joint, at the back, where to be classified as pelvic girdle pain or pubic symphysis pain. It's rare for pelvic pain be spread below the knee, so that's if anyone's having pain on the back, on the buttocks, or on the front of the thigh, but going below the knee, it's not likely to be pelvic girdle pain. Will be more referred pain from other areas. And the pelvic girdle is the main role is to form a link between the spine and the legs. So anything coming from the foot through the pelvis, or from the arm down from the core to the pelvis. So to a weight transfer or a link between the spine and the legs, and when we move, but also help to support the abdomen and the pelvic organs. So incidence, it's very common, 1 in 5 pregnant women, and can affect mobility and quality of life depending on the severity of the symptoms. And usually it's during loading and weight transfer activities, but not necessarily. May include getting up from a chair, walking, stairs, getting in and out of the car. There can be a sensation of instability with pain, and lying flat on the back may be uncomfortable. So it's important to say it's a sensation of instability. It's not necessarily a true instability, because the pelvic doesn't really move, but people describe it as a sensation of instability. And moving, often rolling in bed and things like that when they're lying back, most likely due to the sensitization of the pelvic area in pregnancy. Early diagnosis and treatment can relieve your pain, and important to say when giving advice, especially for fitness professionals, that treatment is safe at any stage in pregnancy or after pregnancy. And as the baby grows, the extra weight and the change of your gravity or the pelvic position when you sit and stand, or you stand, depending how your muscular support and your movement and strategies can put more strain on the pelvis at the front or at the back of the pelvis. You're more likely to have pelvic girdle pain if you had back problems or have injured your pelvis in the past, or have hypermobility syndrome. So not just hypermobility syndrome, because the structures may be already sensitized or have depending on your pain history around the lower back, pelvic and hip area, can make you more sensitized around the area and your belief systems around pain. And we'll get more into the belief system in a minute. So it can be acute or chronic in nature. It can result from a trauma. So if you fall on your buttocks or miss a step, a bit of a jar. But for this presentation, we'll focus more on the pregnancy and postnatal. So in the peripartum period, there's an increase of joint laxity due to hormone change. I don't like to use the word laxity, but there is an adaptation of the pelvic area for the growth of the baby, and the rapid change of body weight and posture to adapt to the growing uterus and baby can put strain around the SIJ and the pubic symphysis, and if we can develop maladaptive strategies. Often, if you have already just one strategy to move, it can be it's fine or not such a big problem. But when you're pregnant with increase of posture and shape, it can become a problem and cause pain. It's important to identify any specific medical cause, so more your red flags, we'll cover it in a bit, that can cause pelvic girdle pain. That's not just mechanical or musculoskeletal. And things like stress fractures, inflammatory sacroiliitis, and ankylosing spondylitis are more like autoimmune disease. Family history and psychosocial factors do have an influence in pelvic girdle pain. I would say the ones I see that didn't get better seeing other physios and other professionals, usually there's a strong psychosocial component. This is a big one. We hear a lot. People come and say in clinic that their pelvis is unstable. When we look at the structure of the pelvic area, so this is a sacroiliac joint at the back. There's a strong ligament structure, and the joint itself is very stable, so it doesn't really move. There's only less than 5 millimeters translational movement and less than 3 degrees of rotation of the SIJ. And as you age, the ligaments get stiffer as well. So when people describe an instability, usually it's a subjective sensation rather than a true instability. You can get a sensitization of the area, and sometimes one side more than the other can give a sense of being unstable, or if there's more tension in one area. So let's say your rotators in one side are really tight. If you lie back or something, that side might feel uneven, so a sensation of being uneven, rather than a true instability. So the sacroiliac joints can be stiff or hypermobile. Again, this term is just a subjective sensation. And in pregnancy, obviously, there'll be an adaptation of the pelvic area. But more commonly, pelvic girdle pain relates to the muscle control and the movement patterns around the area. We'll talk more about this on the prac session, looking at some people, how they move and giving different strategies. So common questions you might hear, often in a group class, how the pelvic girdle pain is diagnosed. So you tell the pregnant woman to discuss that with the midwife or the doctor, and hopefully they will refer you to see a physiotherapist, or if you're a fitness professional, you can suggest them to see a physio. They don't need to see the doctor before, to have a proper assessment and diagnose the series of tests that we do. And in our assessment, we can modify symptoms and give new strategies, and then liaise back with the fitness professional to modify their gym session or add some specific things. So we'll look at the posture, look at the back and the hip, rule other causes of that could cause pelvic pain, and have a tailored program. So you can have a read through. So what they can do if you have to give a generic advice. So keep active, but have plenty of rest more towards the end of the pregnancy when things are, or when it's a bit aggravated. I see people have, when there's a growth spur, like I say, I don't know how to describe it in a different way, but usually around 24, 25 weeks, when suddenly there's like a change in posture, the structures get sensitized. It takes 2 or 3 days, and then, or maybe a week, and then the body adapts itself. So maybe having some more rest there. Standing tall with the bump and bottom tucked in a little, so it's not falling forward into the full lordosis. Sitting to get dressed if it's pubic symphysis pain. If we're standing on one leg is a problem, but again, it's not always a problem standing on one leg with pelvic pain. Having equal weight in both legs, having legs together, going in and out of the car or rolling in bed, sleep positions, supporting the belly, supporting the legs in bed, modify some of the symptoms. So when you're lifting, and have things more even, not just so lifting shopping bags or if you have 2 children, bags and things like that, to have even weight rather than one side more than the other. And standing the weight in one leg more than the other, having equal weight on both sides. So some treatment options so that we can provide as physios. So advice on how to manage, modify movements, a lot of education. So we'll look at the aggravating factors, see what's going on, and give some different strategies in the specific to the aggravating factor. So positions, posture, movements, and pacing, if that's the case. Exercise that can help to relieve the pain, but that will come based on our diagnosis. So sometimes there's too much going on, they need more breathing and releases and stretches. Sometimes there's not enough support on the pelvis, so that's more your strength and specific muscle training. Manual therapy has a place, depending what we see. And in acute stages, just basic pain and inflammatory advice, acupuncture and belt and taping, depending what they are presenting, how we can modify symptoms. So on any questions so far? Because I can't see the screen. So Terry, you tell me if there's any questions there.
No questions have come through yet, but definitely, girls, all ask questions or make comments as we go along, and I'll bring them up on the screen so that Caro can see them. Okay.
Cool. Even if there's, as I go, if there's any patient that comes to mind that you want to discuss or ask a question or comment, feel free to stop me.
Yes, if anybody puts even a little case study with a question on it, we can either talk about it now or we can just keep it for the end, and I'll make sure I refer back to it.
Mm-hmm. So on the assessment, we look at the location of the symptoms. So just remembering, so around the groin area, pubic symphysis, posterior pain, back of the leg, but nothing below the knee. Listen to the history. So when the pain started, the mechanism of injury, if there's an injury, or position. So you have to look at functionally what is causing the pain. Any history of pelvic girdle pain during pregnancy or before pregnancy, or any pelvic trauma. So maybe they had a car accident in the past or some sort of trauma. So it's good to know all of that, how the previous pregnancies were. Birth history as well, if it's not the first one. History of low back pain and hip pain, it's really important, or any leg pain. Beliefs, always ask what they think is the problem and what they think, what they expect from treatment and what they expect from the recovery. And they usually tell you, if I have their fears as well. So if it's early on the pregnancy, they start getting terrified what's going to happen later in the pregnancy, or other people that they know that had a similar pelvic problem. And so they kind of, what they expect. So it's good to ask what they think is the problem, what they expect from treatment, and if they are worried about will affect their pregnancy. So because this will target your education. Ask any previous education they might have had. So what their midwife or their doctor might have told them. So if they say, or if they've seen someone that said your pelvis out, it's unstable, or something, you look for the language they're using. So you can educate or modify what you're doing. The exercise history before pregnancy, during pregnancy, and how this pain is affecting the ability to stay active, and also how it's affecting their activities of daily living. So especially if they have other children and things around the house. Aggravating factors, specifically see the things or ask the things that they're struggling with, because we'll look at this when we're doing our functional examination specific to the aggravating factors. And your usual irritability, severity, and the 24 hours pattern that we would normally do in any physio assessment. Then network support. So if they're struggling with a lot of pain and I have 2 or 3 children, then also look after the house. So ask if they have, family support, a partner, because that can be adding to their pain levels and sensitization. And the work and family environment. So work specifically what physical demands they have, and also pressures and if they feel they can't take breaks, so if they can't modify, that will add to their pain levels, because it'll be another stressor. So that lady that I was talking about, the radiologist, that in her mind that nobody could take over from her, but her work was actually very supportive, giving her time if she needed rest, modify, and take breaks or have some treatment. But for her, she was more the pressure she was putting herself and letting the team down. So all of that kind of increased her pain, rather than she had good movement strategies, but it was more like her sensitization, the pressure that she was putting on herself, and the fear from having previous back pain, endometriosis, and all of that. It's more like pain levels rather than mechanically having something wrong. And that's someone that was doing pregnancy I don't know if she did antenatal work with that before she had kids. No, I think she came pregnant. Yeah. So we did strength work. She was doing pregnancy Pilates, hydrotherapy, hands-on. So she was doing everything right, but her pain was increased from the pressure she was putting on herself rather than mechanically. So other things we'll look at in the history of arthritis or any other inflammatory conditions. So thinking about the sacroiliitis and spondylosis. I can't pronounce that. Ankylosing spondylitis. Any other autoimmune disease, any pregnancy, birth complications, and also don't forget to ask about a history of abdominal surgery or pelvic surgery. I'm seeing more and more people that had abdominal and pelvic surgery early on, and you don't expect unless you ask, and sometimes they don't even say. I've been treating this lady recently with groin pain, but it's mainly because she's got a few hip issues, but also when I started asking more questions, because her symptoms were a bit weird, she had severe endometriosis and had quite a lot of surgery early on. So I think she's actually a combination of pelvic hip pain and pelvic, a complex pelvic pain adding to the mix. So it's good to ask specifically in a history of surgeries, and then clear all the red flags we'll cover in a minute, and the yellow flags, so your psychosocial component, belief system, fear, things like that. I think we talked about this, causes of pregnancy, trauma, arthritis, osteoarthritis, and an exclusion of lumbar cause. And I would add hip there as well. So considering red flags, there's no difference between low back pain and pelvic girdle pain. So there will be some things that will be the same for back pain and pelvic pain, the usual red flag questions. Except that pelvic girdle pain patients are normally younger than 30 years old, so therefore less likely to have malignancy, disease, or cause of pain. Always be aware of beliefs around pelvic pain and history of trauma. It might get into the mix, so that's more like the chronic or complex pain disorders of sexual trauma and things like that. Not so much during pregnancy, but you can have a mix. So physical, emotional trauma in the area. And pelvic pain is complex, so it's not just a load musculoskeletal issue. There's more to it. And I find personally with chronic pelvic pain, we have having a multidisciplinary approach. You get a lot more than just trying to do it all yourself. Like if you have a variety of skills on your tool bag to know how to manage pain by itself, you can approach a few things, but having a good integrated doctor and a nutritionist and some other things, it does help. So in terms of education, suggested biomechanical, pathophysiological focus type of education, your posture and movement is important, but also your psychosocial. Just saying in terms of posture, there's a shift on the center of gravity due to the growing uterus, bit of more load on the lumbar spine, causing stress on the lower back and the pelvic girdle, resulting in some compensatory postural changes and effect on the lower back. So depending the strategies the person is using, if it's more core focus, abdominal focus, trunk focus versus legs, and vice versa, can affect the pelvic from the load transfer point of view. The hormonal influence on pelvic girdle pain is unclear. So we just say, oh, the relaxing is affecting your pelvis. It's not clear. So I would say there's no clear correlation between the relaxin levels and pelvic joint laxity or pelvic pain, more a sensitization around the area and movement strategies. So some risk factors. So women with previous pelvic and lower back pain during or out of pregnancy and a history of trauma to the back or the pelvis area, increase of risk of developing pelvic girdle pain. And I would say, depending how the rehabilitation and the education they had during the previous trauma is really important. Had multiple pregnancies, increased body mass index, physically demanding work, emotional distress, smoking can also increase your risk. Women's risk, age, hormonal contraceptive use, weight, height, and time between pregnancies, they're not risk factors for pelvic girdle pain. Prognosis and recurrence risk. The outcomes for pelvic girdle pain in pregnancy are really good, so that's an important thing to say. It's common, but the prognosis is really good. So if someone comes with severe pain, really scared, fearful to move, thinking, from now it's just going to get worse, and just say, the prognosis is really good once you have the baby. So just some differential diagnosis for your red flags as well. Once you've done your history and your physical examinations, or you'll be able to diagnose specifically pelvic girdle pain. So pelvic girdle pain pregnancy is diagnosed after exclusion of other significant pathologies or obstetric complications. So don't know if you can see there's a list there for orthopedic and musculoskeletal, obstetric and gynecological, infective and vascular. The ones that I've seen more commonly are the ones that are underlined there, some like disc problems, osteoarthritis, lumbar stenosis, ankylosing spondylitis. I've seen a couple of tumors and malignancy, but not very common. Spondylolisthesis, stress fractures. I haven't seen, and sciatica is very common. I haven't seen in clinical practice rupture of the pubic symphysis. Maybe someone that works in the hospital see more often. Osteoarthritis pubis, common, but not. I don't see so much in the pregnancy, or in sporting population. If you have a high level sports person, might still show up in the pregnancy. Osteonecrosis, I haven't seen. And then obstetric, your preterm labor, placenta abruption, chorioamnion diagnostics. I don't know, something with the amniotic fluid. Haven't seen that one. Round ligament pain, very common. Infective UTIs, osteomyelitis, and vascular femoral vein thrombosis. So just some things to keep in mind when you're assessing it's just not making sense, and you do all your tests, there's nothing, all your pelvic girdle pain, your specific tests, symptom modifications and everything, it's clear. Make sure you look for the red flags and refer on. So other history points, this is similar to, some things are similar to your back ones. So pain, absence of mechanical stimuli, unexplained weight loss, neurological symptoms, or called equine sort of questions, incontinence and bowel and bladder dysfunction. So not stress incontinence, more like called equine. Significant trauma into the pelvic or back, vagina bleeding, fluid loss, and pyrexia of unknown origin.
Carrie, I was just going to say, not that these are necessarily red flags, but just a note while we're talking about all those differential diagnoses. For the musk physios and the fitness professionals, just interesting to note that as a women's health physio, a lot of the time the differential diagnosis that people are coming to ask me about is like a sort of a discomfort in the pelvic region in pregnancy, and wanting to know if it could be pubic symphysis versus like varicose veins around the vulva versus prolapse, those sort of things. It's often
more like internal versus pubic symphysis, you mean?
Yeah, just like not red flag, but just interesting with the pubic symphysis that it's also closely related to all the sort of vaginal symptoms and vulval symptoms that we might also be assessing during pregnancy.
Yeah, I think the key there is so that's a subjective part of the subjective, but then when you go and do your physical examination, you can rule out, you can differentiate more, but when it's just symptomatic, it's all kind of in that area, so it can overlap a little. Some other differential diagnosis, osteoporosis during pregnancy, like a transient osteoporosis, osteonecrosis in pregnancy, a vascular necrosis of the hip. They're all like rare stuff, but you can have a read through this in your own time. And pubic symphysis diastasis. Have you seen any of that test before?
Sorry,
any of this?
Back on the screen again. I've seen a couple that I suspected, which I like early on in working at the hospital at St John of God Murdoch, and I'm pretty sure that at least one of them came back with that as a on crutches.
Which one? The diastasis?
Yeah, pubic symphysis diastasis. Like wheelchair bound, like very, very, very incapacitated. But I just don't. I was talking to Jess Hexel about this the other day about pubic symphysis diastasis. I'm just not sure if I've seen any that severe. Have you seen any?
I haven't seen. The one I think but again, I'm in private practice, and if I think they were that severe and couldn't walk, they would have gone to the hospital or to the doctor and maybe referred on. So more like biased population rather than how often it is. I think they're all rare. The ones like the vascular necrosis of the hip or transient osteoporosis, maybe if someone is like a high-level athlete with some eating disorders, and like you've got a bit of a history, then you can think, oh, maybe there's some other stuff going on. Just something to keep in mind, but not your healthy pregnant woman. I don't think you see things like that.
Yeah, it's interesting to know if anybody else who's watching has seen, can you comment if you've seen any of those more unusual, severe red flags?
I always see when you're kind of doing your subjective history and you see there's like, a high-level athlete, like eating disorders, some other things, or like severe autoimmune disease, celiac disease, and some other things that kind of not just a healthy pregnant woman, then you always kind of keep an eye from some more red flaggy type of thing. But the usual, you see it's more mechanical or sensitized pain problems. So that's the location what we see, the most common one. So the front, groins, side of the hips and at the back, so around the lower back, SIJ, but not much further. Maybe the back of the thigh a bit further down, but not too far down below the knee. So 94% of SIJ pain presentation is around here, the black area, the buttock, side and back of the leg. Growing pain 14% and referred pain about 50%. We'll go through this on the prac session, so I'll just briefly go through this. So we'll look at general observation. When I look at observation, I don't look at the pelvis only. This is like, this picture is like the stalk test and some other tests. Questionable, how relevant, and if you don't know what to do when you're doing this kind of measurements in terms of, I do quite a bit of fascia work if I think it's relevant, from the foot up or from the hip down. But if you don't know what to do, fascia-wise, it's a bit waste of time to look specifically in the pelvic landmarks. But look at the body overall, so what the foot is doing, what the rib cage is doing, because the pelvis is in between the upper body and the lower body, so not just the pelvis and the lower back itself. And then so stalk test is some test, some relevance, not relevant, more to see how the ilium rotate posteriorly, tells something about your glute activation. On the symptomatic side, when you measure the symptomatic side, the ilium instead of rotating backwards, stay anteriorly rotated. So it's more indication of muscle recruitment, so like your glutes. And if it's a force closure, lack of force closure, and you do this test, and your treatment will be towards like glute activation type of program. On the pain provocation test, so you see what the problem is. Mulligan is one of the symptom modifications that you can do. Look at the problem is, do different things around the pelvis. Can be like a posterior glide of the ilium, see if it's saying better, worse, and you can do that in different positions. You can do it during sit-to stand, you can do it in a hip extension to reproduce the walk-in single leg stance, or depending on the back movement, you can still apply your glide. Sometimes it's in forward flexion, and then you just look if it's symptomatic, to apply a glide, see if it's saying better, worse, repeat the glide. If it improves the symptoms more than 50%, it can be used as your treatment. And same with some sort of different, as far as symptom modification, you can look what the problem is, change the strategy or the position. So it might be putting posterior tilt if the person is anterior tilted when they're doing, for example, sit to stand, and see if the symptoms are the same, better, worse. And then it's your assessment by your treatment as well. Does that make sense to people? Like just changing strategies? I can't see, so unless I hear, I'll keep going. So diagnostic tests for SIJ. So there are 5 tests, so 3 out of 5 is a cluster of tests. We'll practice this on the prac session. And the way you test needs to be the right way, otherwise you can get false positives. Those ones are some more for pubic symptoms, so active straight leg raise, compression distraction. You can look at single leg stance if it's a shift problem, and your Faber's test, so you can clear hip. So I'd say this one here, it's more SIJ, this one more pubic symptoms pain. So for SIJ pain, 3 test positives for SIJ. If it's 1 or if it's less than 3, not likely to be SIJ, probably from the lower back or hip, or just a movement strategy issue. For pubic symptoms pain, usually do active straight leg raise, look at Faber's as well, muscle tone, and a few other things. Easier for us to do this on the prac. Yeah, if it's negative, not likely to be pelvic, not likely to be pelvic girdle pain related. I just put these slides here. We didn't have this last time. We did because I know some people didn't know much about form closure of force closure. So form closure is just an anatomical structure. So the sacroiliac joint is a synovial joint between the ilium and the sacrum. It's a very stable joint and it includes the ligaments in the area. And the sacroiliac joint, you can have nutation, contra-nutation, that's posterior tilt, anterior tilt, so the tipping of the pelvis. So form closure is just an anatomical structure. Force closure is the muscles that support the pelvis. So we know the pelvis is very stable and strong. So force closure is the term used to describe the other forces acting across the joint to create stability. So we have the bones and the ligaments for form, and force is more the muscular myofascial actions. And the thoracolumbar fascia as well contributes to force closure. When you look at fascia lines, how the muscles and the ligaments that connect from the legs up to the pelvis and to the lower back, it makes more sense. When we do the prac session, we can go through those ligament palpation if people are interested. So your sacrotuberous ligament, sacrospinous, interosseous sacroiliac, long dorsal ligament, and iliolumbar. So if you're into manuotherapy, we kind of work through this. So force closure, so the muscle action, you can have too much or not enough. So if there's too much force closure, so there's too much tension on the muscles that attach into the pelvis or and fascia as well, so causing pain. So they're the ones that I see quite often, because I think most people are quite good at, if there's not enough muscle action there, so doing a glute exercise is your slings type of thing, they'll get better. But if there's too much and you do glute work, if you do a lot of loading around the pelvis, they'll get worse. So it's a different approach, so more releasing the pressure around the area with, some fascia release work, some breath work, some stretches, relaxation, so less action in the area, rather than too much. So if you don't know what you're working with and you just give glute exercise, say it was the common one that people with stability exercise, they will get worse if they have excessive force closure. So just some of the sling terms. You have your rectus abdominis, your abdominis at the front, your ligaments, and at the back your lats, your thoracolumbar fascia that cross over, and your glutes. I tend to work more with the idea of the fascia lines. So the superficial back line, you see, goes through here and through the ligaments. Here we go through the SIJ. So if you're looking at SIJ, you have to look what's happening there, the back of the body. Hamstrings and pubis symphysis vein, superficial front line, so see where the abdominals attached to, and deep front line, so all your adductors, pelvic floor area, diaphragm, soleus, and SIJ looking lateral line as well, so you have your glutes, glute medius there, QL, and all of that. And for the ones with too much force closure, you have to look at this. And I personally, when I'm doing strength work, I look at the fascia rather than specific muscle strengthening as well. So I think I would just stop there. This is what we'll cover on the Wednesday practice session. So we'll do practice of observation, specific tests, diagnostic tests, classification, the education, practice explaining, do some functional tests, some treatment options for symptom modifications and movement strategies, some ideas on what to do if there's too much force closure, if there's not enough, and if we have time, play around with some exercise ideas, not just the usual, glute exercises and core work, just looking a bit outside the box in terms of load transfer through the upper body to the pelvis, lower body to the pelvis, and make it more functional rather than specific one muscle strength type of work.
Thanks, Carol. I'll put the slides away so you can see yourself and me again.
Talking to myself like a crazy person.
I've got some questions that have come through to me separately, so I've put them up on the YouTube so that I can, and I'll bring them over one at a time so you can see them. But while I'm going through those questions, if everybody else could ask any of their questions now, that'd be great. And Cara and I will go through as many of them as we can now. We won't stay much longer than another 10 minutes to make it sort of an hour total. So hopefully we'll get through the majority of questions everybody has. But if not, ask them later, and Cara or I will try and help answer them later or in the session on Wednesday. So first question I got sent for you. Can you go through the way you would explain in layman's terms to a patient or a group of pregnant women what is pelvic girdle pain without the use of the terms instability and laxity? So I guess just...
I like using the sensitized. So during pregnancy, the ligaments and the pelvis itself gets sensitized. So rather than... I usually use the terms of the pelvis really strong, the stronger ligaments, and it adapts to the growing that's my kids coming sneak up on me, adapt to the growing uterus. But in this period, the structures can get sensitized. So either when we're rolling in bed and pressure and exercise sometimes, and what we need to do is to retrain the body to adapt as the body changes, so more sensitized. Rather, and I never use the relaxing thing, and the pelvis is unstable. I just stay away from it. So more sensitized and adapting, and when things are sore, how we can spread the load or move in different ways and things like that.
Are they sneaking up on you still? Are they? Hello. Hi, Annabelle. Okay, next question. Can you go more into differentiating between sciatica and pelvic girdle pain? Is sciatica a form of pelvic girdle pain?
The sciatica, it's obviously a general term for pain along the sciatic nerve. So number one, pelvic girdle pain doesn't go below the knee. So sciatica can go below the knee. Other structures that can refer to the buttock and the back of the leg, it's your facet joints. It can be myofascial, as in trigger points around the area. You can get, piriformis being tight and compressing the sciatic nerve, but as in true back, discs and radiculopathy kind of thing. So if it's pain to buttock and back of the leg, a few things there could be your SIJ, could be your facet joints, could be myofascial. Right. For pelvic girdle, for SIJ pain, you have your specific tests, so your 5 tests. So if there's 3 more out of 5, that's an indication. If it's clear, it's not pelvic. SIJ is not the source of pain. It's likely to be from other structures. So then you have all your lumbar tests to differentiate radiculopathy and peripheral neurosensitization. If people don't know what that is, we can go through on the prac session, but they are very different presentations. And when you're testing, when you do your nerve tests will show up, and then the pelvic on the SIJ test will be negative.
Yeah.
Does that answer?
Yeah, definitely. Yeah, I think the person who asked that probably. And other people who might be thinking about the term sciatica, I guess I just have found that in the general population, sometimes like sacroiliac joint pain, pelvic girdle pain, and sciatica are all kind of interchangeable.
Yeah, pretty much anyone that has a pain at the back of the leg, they come up got sciatica. So I tell people, I say, and that's not just pregnancy and posterior leg pain, like anyone that comes with pain at the back of the leg, I say, well, there are a few different structures that can cause pain at the back of the leg. Let's have a look at you and do some tests and clear out. I had today a lady with pain like lower, so SIJ-ish, she's like 70, 80, but like right at the base. And she was like, oh my God, I got sciatica. So we did all the back tests, like her history didn't indicate, but just for her, I said, look, it's all negative. So just taking that weight off, the pain already reduced, oh my God, I don't have sciatica. And then
my friend had sciatica and it was awful, and I must have it too.
So then you go to the belief. So why is this so important? So what are you worried about?
What's your experience with other people?
What's experience? Why is this so?
Next question. In a group class for pregnant women, would you include single leg loaded exercises or avoid them?
Yeah, definitely. Because it's part of life. We walk in one leg, we stand in one leg, holding newborns, and you always uneven. So you train. I think there was a strong, I don't know if it's a belief system that pregnancy you just don't do single leg work. Yes, if someone is very irritable and if you haven't assessed them before, for your FitRight instructors and for physios that assess people before going to class, it's easy because you can say it's very irritable in single leg, say just stay in the narrow stance or keep in both legs. But for everybody else, so modify. If you have assessed, if you haven't, just do it everything you can with as much variety as possible, and tell them if this is uncomfortable on your pelvis, the front of the pelvis or the back, put your hand up and I'll give you a modification or something like that. But I think it's important to train people in as many configurations as possible to give fascia strength, give movement strategies, so you're not trained in this sort of one plane in one even both leg kind of scenario.
No other questions have come through. So I think we might. Was there anything else I made a note of? No, I think that was all. One other thing that somebody asked me to remember to ask you. That's right. Could you touch on your experience with support garments and belts, and what proportion of people you see in pregnancy with pelvic girdle pain might actually benefit from those? And I know we talked about enclosure and decrease.
Biased population. I think I don't use them a lot. Sometimes I tape them, if it's that kind of gross per kind of scenario, and I've done some techniques that I want to tape them for a couple of days, and then usually after that they're pretty good. Or later, like 40 weeks, they can't handle just to get them through the last few days kind of thing. But and postnatally, as well. Because the people I see, they usually do some sort of prep work, so they're pretty good postnatally. So I don't have a lot of and just like the normal belts, like all the fancy pants and shorts, I don't have a lot of preference to share. Same thing with tube grips and things like that. I think I had experience of trying using and not trying, and haven't seen a huge difference. The difference was more like the work doing prenatal, like during pregnancy to postnatally.
And just to on that topic, I guess still though, just to confirm that you would, if somebody was to sort of bring in a belt and say, should I use this? Or I have a pair of SRC shorts, should I use them? You would look at whether they were somebody who was likely to benefit from some.
So then I'll say, look, I don't know. Let's look at you, do the test, because if you think about if someone that has too much forced closure and then you put a belt on, the number of times I took belts out and shorts out, because it's just adding to the load. Again, because I think most people that have reduced force closure, most therapists can fix with a bit of strength work, but the ones that don't get better, they kind of get a bit lost in the system and then come and see me. Look, I didn't get better. I'm using my belt. I'm doing my exercise. I'm doing my Pilates. But I'm not getting better. And then it's because they've got too much on. Pelvic floor is overactive, bracing the abdomen and all of that stuff. So potentially biased population, but definitely case by case. Still assess them the same way, and then assess if it's necessary and see if it changed function. What's your aggravating. If it's only when you sit to stand, but if any other time is fine, it's probably not relevant. But if it's like end of pregnancy or struggling 24 hours, just need to get through the last few days, that might be relevant.
Yeah. Perfect. Okay, thank you. No other questions come through, so we'll stop there, and we will see you on Wednesday.
Yeah.
And anybody who's watching this now or watches this before Wednesday, please make sure if there are any case studies that you want us to talk about on Wednesday, or anything that you want us to make sure we go through in the prac session, let us know beforehand. And I will see you in person at Eric Street on Wednesday night, Cara.
Case studies are always great, because then we can, if you've tried anything clinically and you're not sure, or if there's I think Jess Hextor had some good ones recently. I think she was even thinking about some red flags, and then she tested or did some x-rays or something like that. It was postnatally, and everything came back clear, and then you go, okay, now what? So it's good to
I know one of those patients she's talking about, which is the shared patient. So I'm looking forward to discussing her.
Yeah.
Okay. All right, thank you, and thanks, Annabelle. Thanks for your
very patient, those two.
See you later, Carol. I'll talk to you soon.
See ya.
Bye.
Bye.